Good morning, everyone. Thank you for joining us today for our journal club. We're going to be discussing two different articles today in one presentation. So this presentation will focus primarily on the theories of depression, theories regarding the neurobiological mechanism for ketamine's antidepressant-like effects, and the interplay between reproductive hormones, depression, and ketamine. My name is Pooja Matadar, and this is Tara Tamton. So the first article we're going to discuss is titled Depression, Estrogen, and Neuroinflammation. It's a review of ketamine's treatment for mood disorders in women. So I'm going to turn it over now to Dr. Tamton, who's going to discuss the theories of depression and provide a brief overview on ketamine.
So we'll start off by going over several theories of the etiology of depressive disorders. So first, we have one of the oldest theories, the monoamine hypothesis, which basically posits that depleted levels of serotonin, norepinephrine, and dopamine, or any combination of these monoamines, will lead to depression. Then there's the glutamate hypothesis, which states that excessive glutamate transmission and decrease in its clearance by glial cells leads to cellular toxicity and reduction in brain volume, leading to depression. There's some evidence for the glutamate hypothesis. Stress increases synaptic glutamate in the hippocampus, and also studies have shown lower levels of glutamate metabolites in the prefrontal cortexes of patients with major depressive disorder. So next, for theories of depression, we have the neurotrophic theory, which states that psychosocial stress results in neuronal morphological changes, including neuronal apoptosis, dendritic atrophy, and decreased trophic factors, which will all ultimately result in depression. Some evidence for this theory is that in patients with MDD, brain-derived neurotrophic factor, or BDNF, levels are decreased, and they're comparatively increased in patients with MDD that are taking an antidepressant. This was a postmortem study. Interestingly, in animal studies, when BDNF is administered, antidepressant effects are they're actually prolonged for about 10 days, which is long after BDNF has degraded. So we have to ask, is BDNF triggering some neuroplasticity? Some other evidence for the neurotrophic theory is that ECT results in increases in trophic factors, and oral antidepressants induce hippocampal neurogenesis. So we'll end here on the neuroinflammatory theory, which kind of ties the other theories in together. It states that both psychosocial stress as well as activated microglia result in an increase in pro-inflammatory cytokines, leading to apoptosis and synaptic pruning, which will all result in depression. Some evidence for this theory is seen when we administer LPS, which is a lipopolysaccharide that generates an immune response, and it causes microglia to release pro-inflammatory cytokines, resulting in reduced hippocampal neurogenesis in rats. We see that the number of activated microglia is inversely correlated with new neurons. Thus, new neurons do not survive around activated microglia. Conversely, inhibiting microglia via minocycline gives rise to an increase in new neurons. So essentially, everything I'm saying just means that activated microglia can be neurotoxic. So this theory ties in with the monoamine theory because when microglia release pro-inflammatory cytokines, it induces the enzyme IDO. So if you look at this diagram to the right, you'll see that IDO is the rate-limiting enzyme that converts tryptophan to kynurenine. When there's more IDO, which activated microglia will increase, more tryptophan is funneled into this pathway to convert to kynurenine, and less is able to be used to synthesize serotonin. Thus, activated microglia might actually be reducing the amount of available circulating serotonin. Now we're going to talk about, just briefly, ovarian hormones and depression. So to preface, the rates of depression are 2 times higher in women as compared to men. One study actually found that the discrepancy between rates of depression between men and women is not further increased in countries with more sex inequality. So this suggests that increased risk of depression in women is not solely due to psychosocial factors alone, but likely also has a biological component. We know that estrogen level changes are correlated with mood symptoms, but this is not a causal relationship. What I mean by that is that it's not that decreased estrogen just equals depression. While estrogen levels are decreased in postpartum depression and in menopause, levels are actually increased in early menarche, which is a time when rates of depression are higher in women. Ultimately, there is some sort of relationship between estrogen and mood symptoms, but it's not necessarily linear. In animal models, we see that removing estrogen and progesterone in mice leads to depressive symptoms, while supplementing with estrogen and progesterone can alleviate some depressive symptoms. There's also surely some neuronal component to all of this. We know that estrogens are neuroprotective in certain pathologies, such as Alzheimer's and multiple sclerosis. And we see that administering estrogen reduces LPS-induced microglia activity, which I discussed on the previous slide, which will potentially reduce depressive symptoms. There's conflicting evidence on progesterone, however, and more research is needed. So now we're going to switch gears a little and talk about ketamine. So single dose IV ketamine has been used off-label for treatment-resistant depression for several years. But in 2019, intranasal S-ketamine was approved by the FDA for treatment-resistant depression. The neurobiological mechanism behind ketamine's antidepressant effects are not fully understood, but there are multiple theories, which we will discuss in the next coming slides. So I just want to give a little overview and background about ketamine. So ketamine has consistently shown short-term efficacy in treating treatment-resistant depression in short-term randomized controlled trials. The most well-studied in these trials is either a combination of intranasal S-ketamine given along with an antidepressant, or IV racemic ketamine monotherapy, or IV racemic ketamine in addition to some pre-existing psychotropic regimen. However, it's been argued that this efficacy might actually be artificially inflated in these randomized controlled trials due to expectancy or functional unblinding. What I mean by functional unblinding is patients that are in the ketamine group might experience dissociative or euphoric responses and are thus unblinded to the fact that they are indeed in the ketamine group. When we look at ketamine versus S-ketamine, there's actually a pretty limited amount of head-to-head trials that we were able to find. We found some meta-analysis studies that showed IV racemic ketamine is superior to S-ketamine, but we found other studies demonstrating minimal differences. But I think one thing to note is that I think it's a bit difficult to directly compare the two in trials when S-ketamine is typically used in addition to an antidepressant, while IV racemic ketamine might be used as a monotherapy. So I'm just going to really quickly go over dosing and frequency of ketamine treatment, and I'll be focusing on IV racemic ketamine here because we'll be discussing that in our next article. So studies have shown that higher doses of ketamine at 0.5 to 1 milligrams per kilogram is superior in efficacy compared to lower doses of 0.1 to 0.2. Interestingly, if you look at the graph to the right, you'll see that 0.5 mg per kg seems to be the ideal dose for reducing depressive symptoms, even more so than increased doses of 1 mg per kg. I don't know if you guys are able to see the graph super well, so I'll just explain it. The bottom, like the lowest line, the brown line is the 0.5 mg per kg dose. And then the 1 mg per kg is one of the colors in the middle. It's the purple one. So as far as frequency of dosing, typically in the acute phase, you would initiate treatment with 4 to 6 IV infusions and then just monitor how the patient's responding afterwards. If they have a limited response following this amount of treatment, you should not expect much more improvement typically. Assuming they do respond well and you'd like to continue with maintenance ketamine, the dosing frequency is really unclear. I wasn't able to find any specific recommendations, and it seems to be more patient specific. It's worth noting that one study did indicate that efficacy didn't really differ between twice weekly versus thrice weekly IV administration. No. So now we're just going to be discussing some theories of the mechanism for how ketamine works in treatment-resistant depression. So just as kind of an overview statement, ketamine is an NMDA receptor antagonist, and we believe it functions as an antidepressant by reversing synaptic and dendritic spine atrophy. So I'm going to focus on the glutamate burst hypothesis here first. So the glutamate burst hypothesis states that ketamine blocks inhibitory GABA interneurons, resulting in disinhibition and therefore a burst of glutamate. This results in AMPA receptor activation and upregulation and ultimately depolarization of the postsynaptic membrane. The postsynaptic neurons then release brain-derived neurotrophic factor, BDNF, And then we have this whole pathway written out, which I'm not going to get into, but essentially second messenger cascades are initiated and ultimately dendritic spine density is increased in the prefrontal cortex. Lending some credence to this theory is that when this pathway is blocked, ketamine's antidepressant-like effects were reduced in animal models. Interestingly, you guys might recall on a previous slide, we said that administering BDNF produces prolonged antidepressant effects for 10 days, which is after BDNF has been degraded. So one possible mechanism for this is actually in this pathway. The tropomyosin receptor kinase B receptors in this pathway autophosphorylate, allowing them to affect cellular function for an extended period of time, which might explain why BDNF produces those prolonged antidepressant effects. And then this is just a diagram of the glutamate burst hypothesis. You'll see on the bottom half of this diagram, it's essentially just writing out the pathway or demonstrating the pathway.
So another theory is that ketamine's metabolites 2R and 6R hydroxynorketamine act on AMPA receptors, which then produces antidepressant-like effects. The ketamine R enantiomer and its metabolites, which are shown in the diagram there, produce a greater antidepressant-like effect in animal models than the S enantiomer, even though the R enantiomer has 4 times lower affinity for NMDA receptors. So this all kind of suggests that the AMPA receptors rather than the NMDA receptors is what produces these antidepressant-like effects. So there's this one meta-analysis found that relative to intranasal S-ketamine, intravenous racemic ketamine, which is a mixture of R plus S enantiomer combination, demonstrates more significant overall response and remission rates than S-ketamine. This may also provide more evidence that AMPA receptors is more relevant when understanding how ketamine treats depression. So next, we're going to go back to this model of the chirinic pathway that was previously shown, and what Dr. Tamton talked about was the IDO. So we're going to focus on the left side of this diagram and on the final product, which is the quinolonic acid, or quin, which is also a neurotoxic metabolite. Now, this neurotoxic metabolite was found elevated in the CSF of completed suicide patients and also in the microglia of severely depressed patients. Additionally, when we administer LPS, the lipopolysaccharide that Dr. Tamton touched on previously, it activates the microglia, and then so we see higher levels of the quin. Ketamine is known to reverse LPS-induced depressive-like behaviors in animal models, but since ketamine has no direct impact on plasma cytokine levels, it's hypothesized that ketamine, which is an NMDA receptor antagonist, actually blocks quin's ability to act as an NMDA receptor agonist. So this all then would lead to a reduction of the neurotoxic effects of quin and reduction in depressive symptoms. There was also mentioned that pre-treatment with ketamine prior to administering LPS actually blocked LPS-induced depressive-like behavior from developing through the proposed mechanism that I just talked about. Interestingly, a small study was done in which quin concentrations were measured before and after ketamine administration in depressed patients. They found that this was the best predictor of ketamine's efficacy and was the only significant predictor of relative change in the Montgomery-Åsberg Depression Rating Scale score. So before we get into this slide, it's important to know that much of the data on ketamine's antidepressant effects have been derived from studies performed on males. However, there are few meta-analyses conducted among clinically treated individuals, which basically revealed that there was no sex differences in ketamine's antidepressant effects. However, this article mentioned a few differences among males and females when it comes to ketamine. So if you can see on the slide, we kind of wrote out the differences and one similarity, but we're not going to go much into detail about this. However, it is important to note that in females, there was an increase in aspartate, which is also shown to be a selective NMDA receptor agonist in the medial prefrontal cortex. Further, it is shown that females required half the dose of ketamine compared to males to produce antidepressant-like effects, but only when both estradiol and progesterone were present. Also, ketamine was eliminated at a faster rate in females, both of which we'll talk about in the next slide. So it is shown that women have increased CYP2A6 and CYP2B6 enzymes, which are both induced by estrogen and progesterone. Now, these CYP enzymes produce ketamine metabolites of 2R6R and 2S6S hydroxynorketamine, which we talked about were responsible for activating those AMPA receptors. So one study found that estrogen and ketamine, or its metabolites, displayed an addictive additive effects on expression of these AMPA receptor subunits and expression of estrogen receptor alpha. So also ketamine and its metabolites have affinity for estrogen receptor alpha. More interestingly, induction of AMPA receptors was lost when estrogen receptor alpha was knocked out. So therefore, there is likely an additive relationship between estrogen and ketamine in the role of treating depression. Next, we're just going to briefly touch on how the hippocampus plays a role in all this. So it's shown on average that there is a reduction of around anywhere from 8 to 10% in the hippocampus volume among individuals with unipolar depression. So as we age, the volume declines linearly in men, but then there was no correlation found in women, which was interesting. So how does ketamine play a role in all this? Ketamine increases hippocampal BDNF, which is found to induce morphological changes in the hippocampus via neurogenesis and synaptogenesis. It's thought that the BDNF gene actually contains an estrogen response element, or that estrogen receptors are on these BDNF expressing neurons. Maybe this is why estradiol mediates dendritic growth and synaptogenesis in the hippocampus. So now we're going to talk about the study on intraoperative ketamine for reduction of depressive symptoms after cesarean delivery, which was a double-blinded randomized clinical trial, which was done in China. PPD is what we call postpartum depression. It is defined by the DSM-5 as a major depressive episode with peripartum onset of mood symptoms occurring during or within 4 weeks following delivery. The estimated prevalence is around 6.5% to 12.9%, and it is higher in lower income and middle income countries, which likely reflects the role of environmental and social stressors. Women who underwent cesarean section were more likely to have PPD compared to women who delivered vaginally, because it's theorized that there are certain adverse outcomes and surgical trauma, such as infection, postpartum hemorrhage, maybe injury to the ureter and bladder, uterine rupture, chronic pelvic pain, and GI dysfunction, just to name a few. These adverse effects might play a role to increase risk of PPD. So like I mentioned before, this was a double-blinded randomized prospective trial where patients who were admitted to the obstetrics inpatient unit at this hospital in China from June 19, 2019 to July 15, 2019 were enrolled. Eligibility criteria included cesarean delivery done at this specific hospital in China, ages 20 to 40, gestational age 37 to 42 weeks, and birth weight of 5.5 pounds to 8.8 pounds. These eligibility criteria is basically what describes what a healthy pregnancy parameters would look like. So the exclusion criteria included history of depressive episodes, or if they were diagnosed by a psychiatrist or mental health professional in the past with MDD. Others include a history of domestic violence, serious complications, or serious foundational disease, risk of serious genetic or congenital disease in the baby, multiple gestations, and maternal weight less than 50 kilograms or greater than 100 kilograms, or height less than 150 centimeters and greater than 180 centimeters. These criteria were included probably to reduce some of the confounds, as patients that fall under these categories might have more complicated pregnancy, which could then affect their mood and then put them at a higher risk of PPD. Since the study was double-blinded, they randomized patients' assignments using a computer-generated random number table. The group assignments and the investigational drug, either ketamine or the placebo, that protocol was concealed in sequentially numbered, sealed, and opaque envelopes, so no one can peek in there and find out what any of the subjects were receiving. So on the day of the cesarean delivery, the assistant would then open the envelope and place the ketamine solution or the placebo into a 5 milliliter syringe and label it with the assigned subject ID. So it's important to note that the subjects, anesthesiologists, and follow-up investigators, they were all blinded to the subjects' group assignments. And so they were also blinded to the investigational drug. This all information was concealed until subject recruitment and follow-up had been completed. So just to clarify, ketamine was not used as an analgesic. All the patients received spinal anesthesia at the level of L2, L3, or L3 or L4. And they were given spinal block solution of bupivacaine 7.5 milligrams, given at 1 milliliter every 5 seconds to achieve block up to L4, or T4, T6, sorry. So then within 5 minutes of clamping the neonatal umbilical cord, either ketamine or the placebo was administered. Now, pre-pregnancy weights were recorded for dose calculation of the ketamine, as the ketamine dose was calculated at 0.25 mg per kg, which was diluted to 5 milliliters with 0.9% saline. So they either received the ketamine or the placebo, which was 5 milliliters of 0.9 saline. Either one of the solutions were injected via IV by the anesthesiologist. So in this study, the Edinburgh Postnatal Depression Scale, or EPDS, was used for the outcome measurement. EPDS is actually recommended by both American College of OB-GYN and the American Academy of Pediatrics as a method of identifying possible postpartum depression. And as we know, this scale is also utilized here at the University Hospital. So just quickly looking at the scale, is asked to assess these symptoms in the past 7 days. We also have included on the side the criteria for depression, or as we all can recall from med school, the sticky caps. So basically just going through it, the first and second questions assess the interest, as it asked if they're able to laugh or find humor in things, or if they look forward to doing things with enjoyment. The third question assesses guilt, as it asks whether the patient blames their self unnecessarily when things go wrong. The fourth and fifth questions assesses psychomotor activity, as it inquires whether the patient has been restless or dealing with anxiety. It's also important to know that some estimates have shown that 60% of those who have anxiety will also have symptoms of depression. And the numbers are also similar for the vice versa. Those that have depression are likely to also have anxiety. Question 6 assesses patients' ability to cope. Question 7 assesses sleep. It's also worth mentioning that it doesn't really assess increased sleep, which can also be a symptom of atypical depression. Question 8 and 9 assesses the severity of sadness, with question 10 assessing suicidality. Now, the responses are all from like a scale from 0, 1, 2, 3, based on the seriousness of the symptoms, but the scores were reversed for items 3, 5, and 10. So the total score is found by adding all of them together for all 10 items. Scores less than 8 indicate that depression is less likely. Scores between 9 and 11 indicates that depression is possible. Scores between 12 and 13 indicate that there's a fairly high possibility of depression, and score 14 or higher means that depression is probable. Additionally, if patients score positive on question 10, which assesses suicidality, even if it's at 1, 2, or 3, that prompts immediate intervention to assess the nature of the suicidal ideations in the patient. And this is very important because it can also place the baby at risk. And another important thing to note is that the scale does not assess appetite, energy loss, or concentration difficulties. So like I said, the degree of postpartum depressive symptoms were assessed by the EPDS scores at weeks 1, 2, and 4 postpartum through phone. In this study, patients who scored greater than 9, which indicated that the range of depression was possible to, if not probable, according to the score assessment. And if they scored greater than 9, they were actually recommended to go get a psychiatric evaluation. Other measurements that were taken was the pain intensity at day 2 postpartum, and this was done by using a numerical rating pain scale score. And sleep duration was also measured at day 2 postpartum. And then, so basically the EPDS scores at each weeks were compared between groups using chi-square, and that was the primary outcome measure. Next, the score of EPDS was performed by ANOVA, and the pain scores were compared between groups using the Mann-Whitley U-test. P-value of less than 0.05 was used to reject the null.
So just going briefly over the results. So when we exclude patients that were lost to follow-up, 153 women were in the ketamine group and 155 were in the placebo group. So at the primary outcome, at 1 week postpartum, there were significant differences in degree of postpartum depressive symptoms between the two groups at 13.1% and 22.6%. However, at 2 weeks and 1 month postpartum, there was no statistically significant differences. I included the percents in there so you can see there was a difference, but not statistically significant. Looking at the secondary outcome, so wound pain and uterine contraction pain was lower in the ketamine group as compared to the placebo group. However, there were no differences in sleep duration. So now we just want to talk about our general thoughts on this study as a whole. So we think that this study has its merits, but there are also several limitations that we'd like to discuss. So first is excluding patients with a history of depression. So I think we can see the reasons they did this just to make the study cleaner, prevent some maybe diagnostic confounds. But I think it's worth noting that a history of depression is one of the strongest predictors for PPD. So excluding these patients might have unintentionally led to some bias. Second, they did not score EPTS prior to delivery. So this is important to consider because PPD symptoms can emerge prior to delivery, so that might have changed inclusion or exclusion criteria. Lastly, and probably our biggest criticism of this study is the dosing of ketamine. So as we were discussing earlier, typical dosing for using ketamine to treat depression is 0.5 mg per kg. So this study used 0.25 mg per kg, which is potentially a subtherapeutic dose. Additionally, ketamine is most efficacious after multiple doses, and the study only used that one-time dose. So this might be why we saw antidepressant effects at 1 week, but not necessarily at weeks 2 and 1 month. However, kind of tying this back into things we were discussing earlier, estrogen might also have an additive effects on ketamine. Women might need a decreased dose of ketamine, so this is kind of unclear. One point that we wanted to mention that we just thought was interesting is that PPD rates are higher in China. One interesting reason for this might be actually a sequela of the second child policy. So after the second child policy took effect, the number of elderly women attempting to bear children has increased. So this has obviously led to increased risk of pregnancy complications and C-sections, which might be increasing the risk of PPD. So I think it would be interesting to replicate this study in another country. So now asking ourselves if the study is relevant to our clinical practice. So one point in favor of it being relevant to us is that screening positive for depression at 1 to 2 days postpartum is significantly correlated with suicidal ideation after delivery. So if intraoperative ketamine during C-sections might reduce depressive symptoms even just for the first week, perhaps that would reduce overall suicide risk, making this obviously relevant to our clinical practice. Another point in favor is that in depressed patients that are undergoing surgeries, ketamine does improve postoperative depressive symptoms and relieved postoperative pain. So pain relief might be contributing to an improvement in the depressive state. However, we think there are some points from the study that are not in favor of this being relevant to clinical practice, predominantly the several confounds. So unplanned pregnancy, perinatal complications, social and family factors, including like low social support, marital difficulties, really any negative life event can increase the risk for PPD. So this study did record employment, and there were no differences between the ketamine and the placebo group, but it did not compare any of the other many confounding factors. So just kind of thinking about this study, all of these factors might have a larger impact the farther removed a patient is from delivery. So when they kind of go back home, go back to their normal lives, maybe those other factors are playing more of a role. So this might explain the differences in depressive symptoms at 1 week versus at 2 weeks and 1 month. So overall, we do not necessarily think that the outcome of the study is super relevant to our clinical practice, but I think some study design changes might increase the power of the study and more research is needed.
All right, well, thank you everyone for joining our journal club. We would like to thank Dr. Kalil and Dr. Malik for sharing their knowledge with us. And now we'll open up the floor to any comments or questions.
Recitations.
Wonderful presentation. I think you guys have to move people from the
Yeah, I'm trying
attendees
to figure
to
out how to do
panelists, or you can make me a co-host and I can help you with that as well.
Okay. Oh, here, we can do it here. I think, Will, I think you're able to talk now.
Am I? Can y'all
Yeah.
hear me?
Yes.
Oh, well, thank you for this journal club. It's very relevant. And I do see the um, issues with some of the study designs. One question I have is in the outcome, they say 13% versus 22% in the depressive symptoms. How do they like measure that? Is it the passing the threshold of the EPDS scale, basically?
Yes, exactly. It was the score of 9, like above 9 counted and below 9 did not.
Okay. Yeah, I imagine, because in the ketamine infusions or intranasal as ketamine, you would do it repeated. And, after the acute course, you would even maintain it since the effect generally see this after 7 days. So, if you measure the outcome after 7 days, it probably wouldn't be too statistically significant.
Exactly.
So I agree with what you said. Yeah, do more like infusions and see what happens,
Right.
But thank you.
Yeah, thank you.
Does anyone have any other questions or comments?
I have one question. First, I wanted to say I thought you all did a wonderful job. This is one of the best journal clubs I've seen for some time. My question is, you talked about different sensitivities to ketamine, and I'm curious, do you think that might factor into the question of whether or not dissociation is beneficial? I know that there's a lot of back and forth between a couple of our faculty on whether or not dissociation helps smooth symptomatology. Do you think there's any chance that it might be different for males and females because of this research?
I think, I mean, that's a good question. I think there's a lot of like other factors that probably go into this as well. I would like to see more research into that. One thing that like, maybe like females, they do have increased like socioeconomic and socioculture burden, and they do have increased rates of like you know, sexual harassment or assaults and stuff like that. So I wonder if like when they do disassociate, if some of those are maybe some reminders that are going to be forefront. But that's something that I feel like needs to be more researched.
I think one interesting thing is that it sounds like at increased doses of ketamine, you have more like chance of dissociative symptoms. And like talking back on like the additive effects of estrogen and ketamine, it was saying that women don't necessarily need as high of a dose of ketamine. So is it possible that using a decreased dose during, when treating depression, actually, do we have lower rates of dissociation? I'm not really sure, but I think it's an interesting point.
Yeah, and going back on that, we actually had a patient on 3 North who received ketamine for treatment-resistant depression. And when we spoke to her afterwards, it did seem like she had a little bit dissociative symptoms. But in her case, it was actually beneficial because she said that it kind of just gave her a little break in reality, and her mom just had passed away. So she was able to kind of just connect and really process that feeling. So that ended up being therapeutic for her. So I think it probably varies between patients as well.
One thought I have in regards to the low dose, because because these patients they recruited, it seems like are not really clinically depressed to begin with, it seems, because they didn't rate it beforehand. So I wonder if they use a lower dose because it's basically preventative IV ketamine, So
Yeah.
I don't know.
That's a good thought. So Dr. Malik actually recommended us to look into this article, and it kind of shows that like the dose that worked the best for reducing antidepressant-like effects was 0.5. And then 0.2, as you can see, is all the way up there. So it could be, but according to this study that was done, it showed that 0.25 didn't really have much antidepressant line effects, and 0.5 and even 1 were better in terms of 0.2.
That's a niche chart. Thank you.
Mm-hmm.
I thought this was an excellent journal club discussion, and you guys mentioned the limitation of the study and seem to have a lot of it, but you've addressed those points very well and very organized, kept us engaged. So thank you both.
Yeah, thank you
Thanks,
guys.
Robert. Well, if no one has any more questions or comments, we'll end it today right here.
Thank you, everyone.
Thanks, everyone.
Thank you, Dr. Matadar. Thank you, Dr. Tamton. See you later.
See ya.
Just stop.